Hi, I'm Steve Hollenberg from Emory. I'm honored to be here and help moderate this session. And it's an honor to introduce Dan Burkhoff, who really doesn't need any introduction, but he is the Director of Heart Failure, Hemodynamics, and Circulatory Support in the Cardiovascular Research Foundation Clinical Trial Center at Columbia, and he's going to talk about basic hemodynamics and phenotypes of shock.
Thanks so much, and it's really a great honor to be invited to participate. And where's Marwan? I don't know where you are, but thank you so much, and BK for organizing this thing. Congratulations on a fantastic start to this meeting. We had a great session this morning. We did our teach session this morning. We had about 100 people, I'm told, and I think it's really a testament to the desire for people to understand the basics of hemodynamics. Because it really underlies what we do. It underlies innovation in development of new devices and new therapies in shock. I think without understanding the real basic stuff, and by basic here, I'm going to interpret the word basic here as simple hemodynamics, not basic like real super basic science, but really simple that everyone should be able to understand. Well, when it comes to the basics of hemodynamics, I think we have to start with this image from Judy Hockman, who really taught us, from the 1990s, from running the shock trial, about the basic sequence of the hemodynamic consequences of an acute reduction in LV, RV, or biventricular contractility, with reductions in blood pressure and cardiac output, leading to the secondary effects of baroreceptor activation. We're all very, very comfortable with understanding that baroreceptors increase heart rate and SVR, but there's another player that we don't talk a lot about, which is the venous system. The venous system contains about 70% of the blood volume, and it's a major player in determining wedge pressure and central venous pressure, and as we'll see, plays an important role in prognostication, and it's a part that we've not yet really studied very much. However, this is the early part of shock, and of course, if this shock state persists, new things happen and make things much more complicated, and a vasoconstrictive state really transitions into a vasodilatory state due to a systemic inflammatory response. Now, when it comes to basic, and I mean simple, we can talk about the hemodynamics of isolated left ventricular failure, where we have a reduction in left ventricular contractility with, again, the activation of the baroreceptors and the increase in heart rate, SVR, and increase in what's referred to as stress blood volume due to venoconstriction that results in the increase in wedge pressure. And in isolated left ventricular failure, there's variable changes in central venous pressure, but there is a significant effect on the RV due to the elevation of the wedge pressure, which plays a major role in determining RV afterload. If there's isolated right ventricular failure, we have a different beginning of the process where RV function fails, and that results in underfilling of the LV, and it's that underfilling that by Starling mechanism reduces blood pressure and causes the same activation of the sympathetic nervous system with heart rate, SVR, and increases in stress blood volume. In this case, we have a marked increase in CVP with variable changes and frequently a reduction in wedge pressure. But in real life, it's usually there is some component or some contribution of both ventricles. And here's where it gets much more complicated, where especially in terms of where we have reductions in both right and left-sided failure, right and left-sided contractilities, and depending on how much the relative degrees of reduction of both will help determine the relative changes in CVP and wedge pressure. So that's really as simple as you can get in terms of describing the hemodynamics of shock. But what about phenotyping? So we've just talked a little bit about hemodynamic phenotyping. We can phenotype shock in many, many different ways. We have the etiological phenotypes, myocardial infarction, decompensated cardiomyopathies, myocarditis, other. And also we can phenotype shock in terms of its severity. And over the decades, there have been more than 30 proposed risk scores. Most recently, We have Dave Barron here, I see in the front row here. We have, thanks to Dave and his efforts, we have now the SKY stages. And very recently, we've got other efforts that are looking at phenotyping shock using machine learning. Well, if we go back now and just look a little bit deeper into hemodynamic phenotyping, this is a plot of right atrial pressure versus pulmonary wedge pressure from the cardiogenic shock working group led by Naveen Kapoor. And you can see here that patients present with a very wide range of CVP and wedge pressure variations. And we divided this plot into 4 quadrants, bottom left being kind of euvolemic state, upper left is left-sided congestion, bottom right, right-sided congestion, and the upper right is a bilateral congestion state. And this really gets back to this issue of changes in stress blood volume and relative reductions in RV and LV contractility. But what we learned was that this congestion profile, what we refer to as a congestion profile, has a big impact on prognosis. And you could see if the patient's CVP is elevated, putting them either in the RV or the bilateral congestion, the mortality is twice as much. So this is elevation of CVP, which is prevalent in more than 50% of patients with shock, is probably the parameter of hemodynamics that's deranged in shock that we go after least aggressively. We're very aggressive about blood pressure, about cardiac output, about wedge pressure, but how aggressive are we about central venous pressure? So there's I think, an opportunity. The other thing that we learned from this plot is that this trend is true whether the shock is due to MI or decompensated heart failure, but what you can see is that the heart failure patients have a lower mortality than patients with AMI, suggesting what has been seen in multiple analyses, and I'll show further, that AMI prognosis and decompensated heart failure, the prognosis is different. And that's what we will see here. This is now another way of phenotyping shock is through the SKY stages. And you see here that clearly there's a correlation, a relationship between both baseline and maximal SKY stages and more in-hospital mortality. And again here, when we break this down by AMI shock and heart failure shock, you see, especially in the SKY D and E, that there's a big difference. This is another way of phenotyping shock, which is by cardiac power output. This was really a takeoff of the work from the shock trial from Judy Hockman, where we saw that the lower the cardiac power output, the higher the mortality. And again, in this study from Hopkins, we see that there's a difference in mortality on the right side between patients with ischemic cardiomyopathy and non-ischemic cardiomyopathy. And finally, what I'm going to talk about just is this emergence of machine learning and phenotyping. And there's been many efforts. This is again from the Cardiogenic Shock Working Group, showing these 3 different clustering that is incorporating information about hemodynamic variables and also metabolic parameters. And we see here 3 distinct clusterings of patients. And in the end here, it wound up, these 3 clusters, there was physiological correlates to these three phenotypes, one being a non-congested, where there's really not significant elevations of wedge or CVP, then the cardiorenal, where we have elevations of CVP and we start to see significant dysfunction of renal function, and then the cardiometabolic, which is kind of the longer term patients in shock, and we see that there are progressive increases in mortality depending on these three phenotypes. And again, especially in this group 1 and group 2, we see the difference between AMI and heart failure shock. So is phenotyping of shock important? Well, probably yes. And I'm sure over the next 3 days, you're going to see a lot of different algorithms for treatment. But I just picked up the INOVA one just for one example, that certain types of phenotyping is very important. As you see in the middle row, that the algorithms depend on whether there's isolated LV dominant, RV dominant, or BIV dominant. The algorithms really depend. So this is an example of where phenotyping has become important in many of the algorithms. And I'm sure that as we learn more, maybe from the machine learning, where we can go deeper into other factors aside from hemodynamic phenotyping, that will get the patients to the right therapy as quickly as possible. I think that's really the main reason for phenotyping, is getting the patient to the right therapy as quickly as possible. So in summary, phenotyping shock can be based on etiology, hemodynamic, risk scores, machine learning, or other factors that we have not yet considered. The outcomes differ between AMI and heart failure shock, even after accounting for severity of shock, with AMI having significantly higher. As we get better in phenotyping, we may find other subgroups that will require more or less aggressive treatment right up front. CVP and wedge are highly variable, but this congestion profile has a significant prognostic implication on survival, and elevated CVP increases the risk of mortality by 30 to 50%. And I think as we learn more about the hemodynamics of shock, we understand that these variability of CVP and wedge are determined by relative decreases in RV and LV contractility and increases in stress blood volume that in turn are likely largely determined by the effects of sympathetic nervous system activation and things we do on the venous system, which is really an untapped area of investigation in shock. Thank you.
So we'll have questions now,
Yes,
if you would stay there. So you can come up to the microphone and ask questions, or you can send them through the app, and there's a mechanism to somebody who's going to come and pick them up and ask the questions. So
while we are waiting for questions, there may be questions through the apps also, just to get Dan's idea. Phenotyping in shock is very important, but this we've been trying to do for a long time. You know, the wet and cold and dry and hot and dry and cold. Does this add to that, or does that change treatment, or is it just a progression of the shock as it goes through the stages? In other words, is the phenotype typical of etiology, or phenotype is just a progression of the shock?
Well, I think, first of all, I think that phenotyping up front is maybe important. Like, we just have a very simple example of AMI and non-AMI, and maybe which congestion profile we're in, that you can determine right up front. And I think that I think what we've learned is obviously time is a big factor in the treatment. As time progresses, things get worse and worse, and the patient gets into a hole that's harder and harder to get out of. So that's why I think phenotyping up front has the potential to have the biggest impact by, again, just saying it very simply, getting patients to the right therapy as quickly as possible. I mean, if you had a phenotype that you could say, this patient, even though he's not in such a dire strait, needs ECMO right up front, and get them to that therapy as quickly as possible, or this therapy, this patient will do great with just Impella. The sooner we know those answers in the course of the disease, we prevent that progressive deterioration to the multi-organ failure and systemic inflammatory response.
Thank you. Anyone from the panel?
Yeah. Can't hear me, but how do you will differentiate between congestions and non-compliance? Because an MI probably patient is going to be more non-compliant and increasing in the pressures than a patient with heart failure who is more compliant, and increase in the pressure is related more with volume. So congestion, although we are measuring higher pressures, may not be the same for both phenotypes.
Yeah. When you say compliance, you mean compliance?
Of the ventricles, because a ventricle that has been normal and gets a acute MI is not going to be compliant, and the pressures inside are going to be high without really being congestion.
You're talking about ventricular compliance and
Yes.
determination of the congestion profile. So here's a place where I have a different perspective than probably 90% of cardiologists or 99% of cardiologists. I don't know how much, but congestion is really not primarily determined, in my view, by ventricular compliance. It's determined by the shift of stress blood volume. And we know this when we've published on this since the early 90s, and multiple other studies have picked up on the same idea. That first of all, the main reason why wedge and CVP go up is because of splanchnic, the sympathetic activation and splanchnic vasoconstriction and shifting of blood from the periphery to the central compartment, meaning both the right and the left ventricles. So right and this will raise both CVP and wedge. Now, which goes up more is that then gets a little bit into ventricular diastolic compliance, and also maybe even more importantly, is the relative RV and LV contractilities, but this will also be modulated by PVR and SVR. So it's a very complex, this congestion profile, which I think is very important. It's a very complex, it's determined by very complex interactions between heart, left, right, pulmonary vascular, systemic vasculature, and volume status. Volume status meaning the state of venoconstriction. So it's not only diastolic compliance.
Thank you. Venu?
I think I enjoyed your talk, and I think your group has done so much to educate us about what these data mean. Going forward, Dan, I know these simple one-time parameters help us put people in boxes, but clearly there's a person who gets a diuretic and the pathway falls and everything's better. So the one thing that worries me in terms of us having actionable items with one parameter on hemodynamics is we don't know who the really quick responsive patients are and who need to get identified early and go on support. Do you have any insights as to longitudinal data? Do you think machine learning or something is going to help us?
Yeah, I think, well, when we get into multi-parameter, I don't think there's one parameter that's going to tell you one way or another. Maybe this is where machine learning is going to be very helpful. I mean, everyone thinks machine learning and artificial intelligence is going to cure everything, which is probably not the case. We're probably overblowing it, but it's certainly there's still probably a good role for good old-fashioned multi-parameter, multi-regression analyses and things like that. But clearly, one parameter is not going to solve the problem. And we have to accept, number one, that there's a huge variability in presentation of patients with shock. There's a huge variability in the progression of shock. And I think this is why it'd be interesting to get a poll why we really advocate hemodynamic monitoring early, because that lets you continually update your if you're going to call it hemodynamic phenotyping, that will allow you on the fly in very short order to adjust your therapies accordingly.
Yeah. Dan, I think it's really important that we all talk as academicians about phenotyping patients based on CVP and wedge, but I think we're also missing a large population of patients in whom they're at community centers where they don't have invasive hemodynamics. And I think we as a community need to build parameters to help our community partners risk stratify without invasive hemodynamics.
Thank you, Joyce. It's critical. I mean, we're not going to have penetration of swans, in the periphery. It's not practical. But on the other side, we do know from data from the cardiogenic shock working group and from others that patients who are treated in the periphery that get transferred have a higher mortality. What that means is that I think that means that we would like to have, let's say, parameters that can be used in the periphery to say transfer. And something as simple as a lactate not clearing, a lactate elevating could be, it could be almost as simple as that. But I think this is where the time factor, getting the patients the right therapy as quickly as possible, and having better communication between the spokes and the hub, this whole model is really critical.
Thank you. For sake of time, just to take the last question for Dr. Banayusi, and then we'll talk.
Thank you so much. Thank you, Daniel. I enjoyed your talk very much. Thank you. I have a question for you and comment. I'm glad we started to talk about the hemodynamics, how important the hemodynamics for us to manage patients in advanced cardiogenic shock. It's very important for us. As important as that, and you have to pay attention to how clean our data is we're collecting from the patient, because you have to have consistency. And that's something we have to pay attention to as well, because sometimes we are measuring patient in half sitting, and in flat, and we try to make a conclusion from that. That's as important as the data we are treating. That's very important. Second now to understand is a wedge pressure of 20 with a mean arterial pressure is 90 is totally different than wedge pressure of 20 with a mean arterial pressure of 50.
Yep.
That's something we need more machine learning to help us to see what's critical and what's the value of that. What do you think about that?
Totally. First of all, with regard to hemodynamic measurements and the requirements, I think that we are, since the early 2000s when there was anti-hemodynamics, anti-wedge, we've lost education of a generation or so or more of the opportunity to train clinicians, especially in intensive care, but that really trickled over to cardiology. So we have multiple generations of cardiologists that didn't really get properly trained. I have a hemodynamic core lab where we look at, studies in heart failure and hemodynamics, and it's crazy what comes into the core lab from sites that are trained. We do training. You should do X, Y, and Z, and still there's really a lack of detail. So you're absolutely right, Ali, that I think we need more training about how to make measurements and make sure that how to zero transducers, how to make sure that you're reading, as simple as reading these things at end expiration and understanding the difference between when a patient's on a ventilator and when a patient's spontaneously breathing. These are all fundamental things that we don't, that it's variable in terms of the education, and we have no quality control. There's no quality control in hospitals for knowing when you look on a chart that the wedge is 30, is it really 30 or is it 15? And it could really be that wide a spread depending on, on the circumstances. So this education part about hemodynamics is critical. With regard to the need, I think it picks up on what was said before. It's not going to be one parameter. We need multi-parametric, assessment. And what it really comes down to is tissue perfusion. And it's oxygen delivery. It's not blood pressure. It's not flow. It's how it's all put together. And even, as you know, if you have a normal blood pressure, or a good blood pressure, normal cardiac output, you can still have peripheral, microvascular dysfunction that's limiting the perfusion to the tissue. So that's another big factor that that needs to be considered. So these are all, I think, that microvascular dysfunction that sets in after time. We somehow need to factor that in. We don't really have parameters for that at this point, but absolutely we need multi-parametric in the end assessments of hemodynamics.
Thank you.
Thank you, guys. It was a great talk and great questions.